Στην νομίζω πολύ ενδιαφέρουσα αυτή σειρά διαλέξεων. Θα ξεκινήσουμε με την κυρία Μάμτα Agarwal από την Ινδία, η οποία παρά τη διαφορά ώρας, αυτή τη στιγμή είναι μεσάνυχτα στη χώρα της, μας κάνει την τιμή να είναι μαζί μας, ζωντανά. Miss Agarwal, we are very honored to have you here with us, considering the sacrifice that you're doing. Good evening, yes. And we are ready to hear you talking about infectious and autoimmune scleritis.
Yes, it's such an honor to be a part of the meeting. Wish it was a physical one, but hope we all enjoy it as much as we would do the physical one.
Αφού δεν γίνεται.
Good evening, everyone. At the outset, I would like to thank my organizers for giving me this opportunity to participate in this wonderful program. In the next few minutes, I'll be talking about scleritis, and we'll see how do we distinguish between infectious and non-infectious scleritis. Scleritis, as we all know, it can involve the anterior part of the eye presenting as anterior scleritis or posterior scleritis, 1 to 5% of the total cases. It can be infectious or non-infectious, and non-infectious again can be diffuse, nodular, or necrotizing. The incidence of scleritis ranges from 3.4 to 4.1 per 100,000 cases. It's more commonly seen in females, the most common being anterior non-necrotizing, non-infectious scleritis. It is most commonly associated with systemic disease like rheumatoid arthritis, granulomatosis, with polyangiitis, relapsing polychondritis, systemic lupus erythematosus, and few others. Infections like tuberculosis, syphilis, Hansen's, zoster, fungal infections, they can also present as infectious scleritis. There are a few cases whom we see that systemic associations as patients with rheumatoid arthritis, the swan neck deformity of the fingers. This is a swollen pinna in a patient with relapsing polychondritis, patient with herpes zoster ophthalmicus involving the left side of the face, a patient with Hansen's who also presented with scleritis. So what is the pathogenesis? It is basically the infiltration of the inflammatory cells into the episclera and sclera. The mechanisms can be diffuse, non-granulomatous inflammation. However, in nodular scleritis, it's a granulomatous response, mainly vasculitic. It can also present as type 2 hypersensitivity, type 3 or type 4 delayed hypersensitivity. What are the symptoms? Patient usually presents as tender, dull pain in the eye involving the periocular area. It worsens with eye movements, radiates to neck, jaw, face, and cheek. Patient presents with red eye or a violaceous hue. There is scleral edema. Patients can also have decreased vision, and it involves cornea or retina. Here's a patient which presents as diffuse anterior scleritis. You can see these corkscrew vessels and inflamed ocular surface. Here's another patient presenting as nodular anterior scleritis. We can see a large nodular lesion in the inferotemporal part of the eye. An ultrasound and UVM confirms the findings. It can also present as necrotizing scleritis. Here's a patient with immune-related necrotizing scleritis. In the next two slides, this is a tuberculosis patient and patients with fungal scleritis. Scleritis, when involves the peripheral cornea, can present with peripheral ulcerative keratitis. Here's a patient with relapsing polychondritis with lesions involving the sclera and the adjacent cornea. Here's another patient with Wegener's granulomatosis with peripheral ulcerative keratitis. Scleritis, on a long term, we can also see staphloma and thinning of the sclera, where we ended up doing a scleral patch graft in this patient. Scleritis, on a long term, we can also see complicated cataract, and this patient, where the scleritis was under control, also underwent phacoemulsification with intraocular lens implantation. If not anterior, it can also present as posterior scleritis. Here's a large nodular lesion adjacent to the macula involving the posterior pole, along with radiating folds in the posterior pole. It can present as a nodular subretinal mass with choroidal folds, subretinal fluid, optic disc edema, angle closure due to ciliary body rotation. Let's have a few cases. This was a young girl who presented with bilateral redness with these whitish lesions in the inferior area in the right eye. She was Diagnosed to have infectious scleritis in both eyes, that was a little suspicious. She ended up undergoing scraping, smear and culture was negative. However, we started her on topical and oral antibiotics, but at 1 week, there was clinical worsening. A repeat scraping also did not show any results. Hence, we diagnosed as non-infectious necrotizing scleritis. She was treated with intravenous methylprednisolone for 3 days, followed by oral steroids and azotherapy. So what we see at 3 months, patients showing healing, all the areas of necrosis, they are healed, and hence this was now an autoimmune necrotizing scleritis. Another case, this was a patient who was diagnosed to have granulomatosis, polyangiitis, and arthritis. She was treated in the past with steroids and methotrexate. However, she suddenly stopped her treatment and developed this red eye with decreased vision, acute necrotizing scleritis with a severe hypotony, and you can see here the scleral melts. At this point, we started her on intravenous methylprednisolone, oral prednisolone, and cyclophosphamide. Cyanoacrylate glue was also done. This is at 1 week. And here she is after 3 months, visual acuity improves to 624. So besides non-infectious scleritis, now what are the cases where we have infectious scleritis? It's a rare cause of scleritis in nearly 5 to 10%. Surgery and trauma being the most common etiological factors. The pathogenesis, it can be exogenous or endogenous. It can be a direct invasion by the organism, or it can be a hypersensitivity reaction to the organism. What the literature says, if it's a post-surgery, Pseudomonas aeruginosa is the most common organism, but if it is trauma, Aspergillus was most commonly seen. How does it present? It can be a nodule or it can be an ulceration. As we see here, this is a nodular lesion and the scraping showed nocardia infection. And this is another patient who had a nodule and this is a pus point, but this was multiloculated lesions with ulcerations over the top. This is another patient where we see it can be a unifocal presentation, or it can be multifocal lesions. As we see here in these patients, there are multifocal nodular lesions. And this is a patient who had ulcerations, multifocal, and now proven to be nocardia. What are the various etiologies? It can be fungus, as we see here, Candida albicans in an HIV positive patient. When it is Pseudomonas aeruginosa, it can also involve adjacent cornea. And these are nocardia lesions, which are more commonly presenting as multiple nodules involving the sclera. And here's a patient who developed herpes zoster sclerokeratouveitis a month after she developed these lesions. Another interesting case, a 50-year-old patient who had a history of fall of vegetable matter while working in the fields 10 days prior to the symptoms. He was diagnosed as scleritis with decryogenitis. The workup was normal and he was treated in the past with intravenous and oral prednisolone as well as antibiotics. So look what we see. It's a scleral necrosis with areas of scleral thinning, tortuous vessels, and again a yellowish-white lesion here. Anterior chamber did not show anything, underwent scraping, and now gram-positive filamentous bacteria was seen. We started him on fortified amikacin, moxifloxacin, Bactrim, and indomethacin. This is a smear report where we can see gram-positive filamentous bacteria. The culture also shows growth, and DNA sequencing confirmed as nocardia and amamiensis. 1 week, we are seeing some changes with hypopion, but still on follow-up. This is a patient showing regression and 2 months complete healing with amikacin, cefuroxime, and oral antibiotics. Another patient I would like to share, this is a 78-year-old patient from Sri Lanka who was again diagnosed as scleritis and treated with oral steroids and methotrexate for 7 months. The collagen workup was negative, but just before a week he presented to us, he underwent a scleral biopsy which picked up Fusarium solani. This is a presentation. You can see AC exudates, small pus points in the inferior area. Fundus did not show any view and ultrasound showed few vitreous echoes. A repeat scraping did not pick up anything, but he was started on natamycin and voriconazole along with oral voriconazole. 3 days, cornea perforated, and at this point, again, a repeat scraping showed Fusarium solani. AC was reformed. A glue BCL was done. And this is a patient post cyanoacrylate glue application, but we still see pus points. You see in the inferior quadrants. So 6 times we drained the pus, scleral debridement, subconch voriconazole wash also was done, and topical and oral antifungals were continued. At 7 weeks, he was responding. And this is at 2 months. This is a corneal scar with complete healing of scleritis. So how do we differentiate? We differentiate infectious and non-infectious scleritis based on etiopathogenesis, where we see this is a direct invasion or it can be an autoimmune response, post-surgery or post-trauma. And it can spread from adjacent structures like endophthalmitis, panophthalmitis. But however, in non-infectious scleritis, it's basically related to connective tissue disorders and systemic vasculitis. Clinical signs, as we saw in the previous cases, we see ulcers, abscesses, purulent exudates, and also hypopion is a key factor. But in the non-infectious, we see either a diffuse or nodular congestion, but there are no abscesses. Workup, again, it's a basically microbiologic workup. Here, it is a collagen work. Treatment, again, it's all antimicrobials. Role of steroid is controversial and contraindicated. But here, we have to use topical systemic corticosteroid along with immunosuppressive agents. So, in immune-related scleritis, I would emphasize steroids, oral intravenous, non-steroidal immunomodulators, and biologics in cases with recurrence and no response. But in infectious scleritis, we have to be careful. Antimicrobials, scleral debridement, patch graft. As a patient who was diagnosed again as non-infectious scleritis, but scraping showed Burkholderia species. At 7 months, complete healing with no recurrence. This is our patient we published in our journal. It's a Candida albicans in an HIV-positive patient. Patient was treated with amphotericin, complete healing. And this is another patient who was diagnosed to have Mycobacterium tuberculosis. But it was on clinical biopsy, picked up nocardia scleritis, and here it is 7 months later, complete healing. And Mycobacterium abscesses, this is one of my recent case where the patient was treated with oral steroids 3 months, but the nodular swelling did not regress. And scleral biopsy picked up again, it's a Mycobacterium abscesses. And 7 months on clarithromycin, IV and topical amikacin, complete healing was seen. So what are the steps of management in these patients? A careful history taking, complete external examination with slit lamp examination and fundus examination. Ancillary tests, they help us to come to a conclusion. Blood investigations in non-infectious scleritis, but a complete checkup by an internist is also very important. Treatment is according to the diagnosis, but we should know what are the adverse effects. This is a patient who was diagnosed to have diffuse scleritis and rheumatoid arthritis. But look what we see, the corneal lesions developing after a few months. And this was herpetic stromal keratitis. And the patient was treated with oral valacyclovir and topical steroids. There's another patient, she was put on tofacitinib, and she develops bilateral herpetic keratitis. And here's one of my patients who had VKH disease and prednisolone and azathioprine-induced immunosuppression, picked up viral stromal lesions in the cornea, and then patient was again stopped the treatment and we started on oral antivirals. So what is the take-home message? Scleritis, it is indeed a diagnostic challenge. It's the first manifestation of systemic autoimmune disease in cases. A detailed history and targeted investigations is mandatory. Infectious scleritis should be suspected in cases of indolent progressive scleral necrosis with suppurration, especially when the patient has a past history of trauma, surgery, or chronic use of topical steroids. Diagnosis is often elusive as the organisms, they lie deep within the sclera. Antimicrobial therapy should be started as soon as possible, and surgical debridement of infected and necrotic tissue is very important. Thank you so much for your patient hearing.
We thank you, Dr. Agarwal, for this very educative talk and the breathtaking cases that you've showed us. Do you have any questions? Any questions from the audience for Dr. Agarwal? Then, if I may ask you a question, then, in cases of infectious scleritis, I've seen that you very frequently solve the case with DNA sequencing. In these cases, how do you suspect which agent to look for? Or do you have a panel of most common organisms that you run the PCR for?
Thank you for a very interesting question here. So basically, when I suspect a case with an infectious scleritis, the first point is that we have to do a scraping. If it's a pus point, then it's quite obvious that we can do it in the clinic room only, and we don't have to take the patient to OR. And most of the time, for the first thing is a gram stain, KOH stain. And if it's a long-standing and I'm suspecting nocardia, mycobacteria, then we also tell them to do acid-fast staining. So it's a package now, infectious scleritis, having seen so far. I now tell them at the first set that look for nocardia and mycobacteria also, because these are the most common things. So they're easy to pick up. But I've seen that a couple of cases where these are deep-seated infections, these are nodular lesions, I have to do a scleral biopsy. And when on table during the biopsy, I feel that there's a necrosis or a pus, but most of the time what happens, the material is so tiny that we tend to miss it. So in that case, we always send a minuscule to a PCR, and we have the advanced PCR test. So one sample always goes now for the PCR test. So if we're not able to pick up on the culture or whatever the smear studies, then PCR does help. And in a couple of cases, we were able to clinch the diagnosis with the PCR. Like this nocardia case, which we had published, it was treated as Mycobacterium tuberculosis, and he was on for 2 months of therapy. But look at what we see, the pus lesions, and then we could make out the nocardia, which was on DNA sequencing.
Okay. Very well.
May I also ask something? In your clinical practice, do you meet more often infectious or non-infectious scleritis?
I practice in a place which is like a tertiary care center, and we have like 1,000 patients a day. So I would say that probably it is a bias where we see, because it's a referral center from the country. So I do see at least 2 cases of infectious scleritis every month. So if I say, I would not say that it's very common, but yes, being a tropical area and depends upon the population. These are all patients where I see less after surgical exposure, but more after trauma. So the patients who are like working in fields or, the farmers and they are more common for that. So it also depends on that. But I would not say that it is really very common here. It's just because we see a lot of referrals that we tend to pick up these cases. But I guess now it's the awareness, because all these patients, if I see, 90% of the time they were all treated as immune-related scleritis. So the message has to be clear that if it's not getting treated and if we are still seeing a persistent infection pain, then the thought is that we have to go for a biopsy or a scraping. Then we have to think about infections.
Thank you very much.
May I ask one more thing? In cases you need to graft, which is your preference? What means of grafting do you use? Sclera or pericardium or what?
We have sclera because we have an eye bank in our hospital. Okay. So sclera is always easily available. Okay. But if not sclera, let's say even the corneal tissue, which is a discarded one, we can use that.
Thank you very much.
So we've used both corneal and scleral tissues.
Thank you.